if you think about the depth and the breadth of issues that our legislature and Congress have to deal with every single day, there's a lot of information on a multitude of issues, and how can they be expected to know exactly without having conversations from people that they trust?
The business of healthcare is hard, creating a badlands of terrain that is difficult to navigate. Some think the most brilliant minds in business are on Wall Street. They are wrong. The most brilliant minds are in healthcare. They have to be to thrive and survive. This podcast explores concepts in leadership, management, sales, and negotiation with those brilliant minds. The Healthcare Badlands podcast is generally planned, but unscripted, unedited, and uncut, so you get the honest and unfiltered experience. Your host is Dr. Tom McDougall, a 30-year veteran of healthcare with 23 years of hospital CEO experience. His guests are carefully selected experts from across the industry. They offer insights, expertise, and some great real-life, often hilarious stories. Now, let's jump into the episode.
Welcome to the Healthcare Badlands podcast. Today we have a very special guest. It is the new president and CEO for the Alabama Hospital Association, Danne Howard. So Danne, welcome to the podcast.
Thank you, Tom. It's great to be here.
Well, I'm glad you're here. And your visit with me is exceptionally timely because the big, beautiful bill, as it's referred to, and I can't even tell you what the actual numbers are for the bills in the House and the Senate because it's constantly referred to as a big, beautiful bill. But talk to me about that bill and the implications for healthcare organizations.
Sure. First, it did just become law 2 weeks ago, or not even quite full 2 weeks ago. So we are still trying to digest a lot of the specifics. As you know, it was like 1,000 pages. So I can say that for Alabama, unlike a lot of our colleague states, but for Alabama, we did not necessarily, for Medicaid and for Medicaid funding, did not necessarily lose anything, we don't believe. Again, still digesting some things. In other words, we think we're kind of status quo. What we may have lost, though, is the ability with some flexibilities to do better. And to do better, I mean by perhaps covering more individuals who would qualify or increasing reimbursement to not just hospitals, but all providers, physicians, and everyone else. So again, still looking at everything. Bottom line, I don't think that we lost anything other than perhaps some flexibilities.
How is it going to impact states like Alabama? Because Alabama is not a Medicaid expansion state as defined. I know you do some things to expand Medicaid, but how did the bill affect that going forward?
For us, well, two things for Alabama as far as our ability to close the coverage gap in the future. One of the things that was enacted during the American Rescue Plan Act right after the pandemic was a bump in a federal match between the state and the federal government for states who had not yet expanded or closed their coverage gap. So in the Big Beautiful Bill, that additional financing has been removed. So that kind of takes away some of our financing ability without finding additional revenue in Alabama, which is difficult to do because our budgets are pretty lean and conservative. And we support that, but it's just going to make it a little bit different. The work requirements that are applicable for the expansion population, clearly since we did not close our coverage gap, since we have not expanded, that's really not applicable in Alabama. You know, those are for individuals between 19 and 64 years old who are able-bodied. Well, in Alabama, our Medicaid program does not cover that population regardless of their income. So I don't think that that's going to be any impact for us at all either. A lot of things, including what I mentioned earlier, that we don't think necessarily we lost anything in funding, because the bill for states like Alabama who have not expanded, it froze our provider taxes at the current rate where it is now, which is good news for us. It does not have to decrease. We are, however, still going to have to wait, and it's going to be a while to see what regulations that CMS puts out to govern the specifics.
Okay. And that was my next question is usually when legislation like this passes, they delegate a certain amount of follow-up activity or next steps that have to be taken by one of the government agencies, in this case, CMS. So what do you believe will be the timeline for CMS to kind of dial in the rest of this so we truly understand the implications?
Yeah, that is exactly the question I asked on Friday on another call with some experts in DC. And the best answer I can give you is I don't know. I would say probably months down the road. And when I say months, it could be as late as late fall before the end of the year, we certainly hope. But I do not think we're going to see anything anytime soon. You know, one thing to remember, not too long ago, the courts overturned something called the Chevron rule. And the Chevron rule said that, or had been applied such that in legislation, sometimes all of the specifics aren't laid out. And it gave federal agencies the ability to implement rules and regs using the interpretations of things because they are the subject matter experts in each agency. Well, that's been in place for decades. When that got overturned, now state agencies do not have the ability to interpret certain things. In other words, if the legislation does not specifically reference something, an agency can't interpret it to mean whatever they think might be best. So there are some things that we're a little uncertain about on how the regulations or exactly what the regulations will include.
Okay. And regarding and I know you talk to the state Medicaid agency in Alabama on an extremely regular basis. How are they responding to this? Is their interpretation of the bill similar to yours, or do they have different concerns?
It is, but I'll say the same as they're still doing what we are in the process of and digesting everything as it relates to what they need to do. I do think, again, I think that their feelings are the same as what I expressed earlier. We may not have necessarily lost anything as far as the funding mechanics go, and there might not be a lot of new provisions. The only thing I think that they're trying to get their arms around, and we are too, is presumptive eligibility. When an individual comes into a hospital and uninsured, doesn't have anything, and it is discovered that because of their income level or in their medical condition that they might qualify for Medicaid, like a pregnant woman comes in because they have heretofore had no insurance, had not had prenatal care. Presumptive eligibility means, hey, you probably will qualify for Medicaid, so we're going to help you get enrolled. And from the minute that that starts, then reimbursement can be retroactive to when that first visit happened. That time period has now been shortened. And so previously it was 3 months. Now for non-expansion states, it's 2 months. That does not sound that terrible, but it can be that it might take the agency a little bit longer to process the paperwork after the hospital and the providers work to get everything in. So that could be very impactful to the provider. Now, the hospitals are going to provide the care regardless, but it certainly is helpful, obviously, from the financial strains if there is reimbursement available.
Absolutely. And I know Alabama, state of Alabama is very specific in how the relationship with CMS is for the Medicaid program. Can you give us an overview of how Alabama handles that? Because it's not real unique, but it is unique. It's different.
Well, I can speak obviously for the hospital side of it, and we are completely unique on how we fund the hospital program in the state of Alabama. In Alabama, we have a hospital provider assessment or tax. We just don't like the tax word, so we have a hospital assessment in which hospitals pay a voluntary tax. We tax ourselves to provide the state with the state match to draw down the federal funds for the hospital program. It's not a consumer tax. It's not passed through. Hospitals can't adjust their charges even when costs go up. Our charges are not set by us. So in that provider tax, we 100% support the hospital program. In simple terms, the state of Alabama does not pay anything for the hospital program of the Medicaid agency. That is unique in that there is not another state in which the provider tax supports the program 100%. In other states, their provider taxes are supplemental to their budgets. In Alabama, our provider tax is fundamental. And if for some reason, which is why we were concerned as the big beautiful bill was moving, had that decreased, the Alabama Medicaid agency likely, or the state of Alabama, does not have the finances available to make up the gap. And without our tax and without that ability, our Medicaid program ceases to exist because hospitals have to be a part of the core part of the program.
Yeah, I know a number of months ago, there were some clickbait headlines that the ability for Alabama to do that was going to change at the federal level, and then it just kind of went away. Why did it go away? What did something significant change in the plan for the legislation?
I think so. I just think, there are a lot of good things. And in my almost 30 years, I find this to be true on a lot of things, and maybe for me too. A lot of things might sound good on paper until you understand what that really meant. So I'm not sure that there is always a complete understanding, and that's okay. Everyone can't expect to be a subject matter expert on everything. We're grateful that people listened and that our lawmakers heard us, and we're willing to listen to the impact that it actually would have had some of those changes that were being discussed early on actually happened.
Okay, excellent point. Now, I know your background, so you're very unusual that you have absolutely paid your dues at the Alabama Hospital Association for more than 30 years. And you worked your way up, and you were you became responsible for the state advocacy, and then you took over federal advocacy, and now you find yourself as this CEO of the association, which is fantastic. Talk about state advocacy, though, because I think people see the headlines about things that may go on in Washington, but they don't see the headlines about all the things that a hospital association has to do at the state level.
Yeah, and I appreciate your qualifying that I'm quite unusual statement, because I think there's a lot of people that would agree with you. But I appreciate that.
As a compliment, of course.
I know. I got it. And we go far back, Tom, you and I. So at the state level, it's much the same, although obviously much more concentrated and specific. In any legislative session of probably 2,000 bills that are introduced, or legislative proposals that are introduced into the state legislative session, we, the Hospital Association, will have maybe 250 to 300 bills that we are actively working on, that we're trying to figure out, that we're trying to help along, or maybe give a different perspective, or like I just said a minute ago, make people understand or help people understand the actual implication, the real world implication of what might have sounded good in concept. So it is quite busy. Alabama session is 30 legislative days within 105 calendar days. It's a compressed time, and 24 hours a day, 7 days a week almost, working to make sure there's a lot of information to have to digest in a very short amount of time. And we have a great team, as well as really strong engagement from our hospital CEOs across the state, who engage in reaching out locally to make sure that the lawmakers understand what their proposals will mean at the local level.
Makes sense. So is the success to advocacy, is the secret to that the grassroots level, or what would you say is, your real success that you've accomplished over the years?
Oh, I think it's a little bit of everything, but I think the biggest part I will say for me, for us, and for our CEOs is the relationships. In other words, we have relationships with our lawmakers to start conversations to help them get a little bit of education on the front end about hospitals before they ever need anything or before we ever have to debate or discuss an issue. Now, trust is everything, and word and honesty and integrity is everything. So, over the years, it's very important that you have relationships enough that I have lawmakers call all the time to ask me questions about healthcare issues that are before them. Not all of them are necessarily hospital specific, but I'm grateful that I've earned the spot to be a trusted source. So I'm not going to tell a lawmaker what I think that they want, what I want them to hear. I'm going to tell them the actual impact so they can make an informed decision. Now, if it's a bad decision or if it's a bad proposal, I don't mind sharing my feelings about it, but it's so important just to be open and honest. So, the term lobbyist gets a really bad rap, but a lobbyist is actually an educator. In Alabama, our legislators do not have staff to research issues. So it's our job to help let them know from our industry, and our industry really touches everything there is in healthcare, not just a hospital, but also bricks and mortar and the hospital physical plant itself. So just to be able to be trusted with information that aids informed decisions.
Makes sense. Yeah, I've always liked the word advocacy versus lobbying. It's because it is completely different. And you're right. I mean, the most success you have is when that state legislator or federal member of Congress calls you not to ask your opinion on a bill, but to say, inform me about the dynamics associated with this. What are the consequences of the bill passing? What are the unintended consequences of the bill passing? That educational component definitely is the most powerful.
That's exactly right. If you think about the depth and the breadth of issues that our legislature and Congress have to deal with every single day, there's a lot of information on a multitude of issues, and how can they be expected to know exactly without having conversations from people that they trust?
Yeah, well, it's impossible for them to understand the healthcare organizations at the level that you would understand them because they have, I don't know, 30 industries that they've got to be informed about, if not more. So that makes total sense. Okay, so yes, I mean the big beautiful bill was passed, and I know there was a lot of build up to that. But what about going forward? This episode is sponsored by CO Management Solutions, a revenue cycle company you may not have heard of, but you need to hear this. There is little healthcare organizations can do about inflation-related expenses, but you can make sure you're collecting 100% of your revenue you have earned. CO uses AI and the latest technology paired with an efficient team to aggressively collect your hard-earned revenue at an attractive commission. Start today with a free analysis of what you are leaving uncollected and recover that revenue quick with CO. For more information, visit coms.com. That is SCIOMS.com. So as you look towards the remainder of 25 and 2026, what concerns or opportunities do you see on the horizon at either the federal or the state level?
A lot, on both challenges and opportunities. One question I had when the announcement of my new role as president came up is, with all the challenges, why the heck do you want that job? And my answer is because it's a very exciting time. It is very challenging, very stressful, but it's also very exciting to think about how quickly the healthcare delivery system is changing right now, maybe faster than it ever has, all in a lot of the delivery methods that are changing. We learned a lot during COVID, and a lot of things changed during COVID, but a lot of new stresses were also put on the system that probably were demonstrated during COVID like they wouldn't have been demonstrated in any other way. And matter of fact, there are some of the things that I have said sometimes is, see, we told you so. We told you so before the pandemic, and now you see what we were talking about. So, in looking at things moving forward, we actually have a task force that we just recently pulled together to start looking at the healthcare delivery system, specifically hospitals to start with. What services are available and who's doing it, and where are the gaps, and how can we maybe have regional approaches to do better, to do different, thinking outside of the box on new delivery methods. Every hospital, particularly in the rural hospitals, they can't be everything to everybody. In other words, they don't have the ability, the equipment, the staff, or the size to be the most tertiary, to provide the most highest level of care, but they can do an awful lot. So what can we do to maybe better utilize the resources so that rural hospitals can play their role and take care of their communities at the level that they can? And when an individual needs a higher level of care, then transfer to a larger hospital with more resources. One of the things that, again, this is one of the, hey, we told you so moments from the pandemic was the entire healthcare delivery system all has to work together and function as one chain in a link, right? So if the rural hospitals are not there and they're not able to care for the things they can in their community, our urban hospitals don't have the staff or the space or the stuff to absorb the volume. So everything depends on each other, and most importantly, it's what's the right thing to do for our communities.
Makes sense. Well, there are a lot of other advocacy groups in healthcare. So you've got Nursing Home Association, Assisted Living Association, Pharmacy Association, physician associations. How do you work with all of those? And what is kind of the cadence that occurs when you have mutual interest, but you also have mutual disagreement, where a bill may positively impact one side, but negatively impact another side?
And that happens. And I'm grateful and fortunate that we all have great working relationships with all of those other associations, some stronger than others. It's communication, it's sitting down at the table. Politics is the art of compromise, and looking for us, what benefits every other industry benefits hospital. Let's talk about physicians just for a moment. Most of the time we're completely aligned on things. Hospitals depend on doctors, obviously, but doctors also have to depend on hospitals for a place to admit and to treat their patients when they're the most ill. So working together and having a lot of communications on the front end of issues. Now that we try really hard not to bring a proposal to the legislature to be introduced that we haven't already talked about. The element of surprise is not always a good thing. And so having relationships where you talk about things before they get introduced, and sometimes we have to agree to disagree on some specifics, but that's rare that we really go head to head and just can't find a place that we agree.
That makes sense. All right, let's switch gears a little bit. And I started my career in rural hospitals. So I operated some very small hospitals early in my career. But one thing that's very curious to me is we have now been told for 3 decades that rural hospitals are going to close. But it doesn't ever seem to happen, not at the scale that's threatened. There may be one here, one there, but I saw a headline just 4 or 5 months ago that said, with the new administration in Congress, we're going to have this rapid acceleration of rural hospital closures. But it hasn't happened. So my concern has always become that it becomes the boy that cried wolf. So it gets said too often and then doesn't actually happen. And therefore people don't get concerned. But these rural hospitals are not only the lifeblood of safety and health in their community, they also are often, if not the largest private employer, they are certainly top 2 or 3. So what is your take on that situation? And am I correct in my assessment that perhaps the boy that cried wolf has caused some issues?
Yeah, I'm glad you said that. We talk about that internally often. I have not ever used the term cried wolf, but it is more the white noise. It becomes white noise because it's the same thing. Now, we have had a couple of hospitals close over the last couple of our last 3, 4 years, and we certainly have about 20, 19 or 20 who are at deep risk. What happens though, I mean, I work for really good people, but what happens is they might not close, at least not yet, but they have to cut services, they have to lay off jobs. I mean, you hear more and more every day that someone had to close their labor and delivery department. And so now we have fewer hospitals that have the ability to deliver babies. Some women have to drive an hour or even two to get to the nearest hospital to deliver a baby. Or maybe it might be that they had an MRI machine that doesn't work anymore, and so they don't have the capital to fix it. So now someone has to drive an hour or two to get a mammogram. We have a couple of areas in the state where the closest mammogram is an hour away. So it is the elimination of services and the elimination of the access to care at the local level that starts to erode. And that doesn't get as much highlighted as it does the closure. So we really try hard not to say hospitals are going to close, but hospitals could close. But we pull rabbits out of hats, and some patch comes along here or there just to sustain for just a little bit. And so you're right. People say, well, you've been saying that for years, and now nobody's closed, and I don't understand. It's a difficult message because without those patches that come along from time to time, they probably could have closed, or without the elimination of services, and that means elimination of jobs. They could have closed. So there are an awful lot of things and concessions being made and workarounds happening. The reserves that hospitals had, not strong in some cases before the pandemic, are completely exhausted. So we find ourselves in maybe some financial strains a little exacerbated even since the pandemic. But that's one of the reasons why I mentioned earlier, we have a task force, and so do a lot of other areas in our state government, and locally and at the state level have a focus on what can we do for some reforms to bolster the rural communities and therefore also bolstering the urban areas for access. So yes, you're right. You're exactly right. It has become white noise. It's real. It's real, but there are patches and there are cuts that don't get the attention that have avoided the closures.
What would need to change so that the patches are no longer necessary and the white noise can subside? What really needs to change either at the state or the municipality, local government level so that this isn't a regular topic of conversation?
Well, that's a really good question. And it's not one thing, but it is a lot of things. But it is also, a lot of it is at the root, and this is also so often misunderstood. It's financial, it's reimbursement. Alabama's hospitals are the lowest reimbursed in the nation, and that includes Medicare, Medicaid, and commercial insurance. So we are the lowest reimbursed. It's physicians, it's hospitals, it's all of the providers receive the lowest amount of money for providing the exact same service as other states. Well, it's just like in my own household and yours too. You can't stabilize your own finances if what you have coming in is not enough to cover just the basics that you need in your mortgage and your power bills and your gas to get back and forth to work. So it's kind of the same for us as inflation grows, as cost of labor increases, as cost of supplies increases, our costs go up, but our reimbursement does not. At least it's not necessarily or anywhere close to keeping up with the increased cost. So first we need to look at reimbursement. Some of the issues rural hospitals have with physician coverage medical professionals. It's very difficult to recruit a medical professional, a physician or a nurse practitioner into a rural area if they can't make a living. And they can't make a living because the reimbursement levels are inadequate and the number of uninsured individuals in rural areas are usually disproportionate. So it makes it a challenge. So the first thing we need to do, and we can look at, is what can we do to increase that reimbursement?
Okay. Makes total sense. And we could go off about three different directions on that. But I want to go
Yeah.
to something you just said, which is, the rural areas tend to have more population that is uninsured. It's a fact. Okay. So it's not a debate. It's not a discussion. It's factual. But Alabama is not a state that has expanded Medicaid, which could potentially impact that. So what's your take on that? So Alabama hasn't expanded. Why have they not expanded Medicaid?
Well, previously I could have said finances. I will say that over the course of the last two previous years, in partnership with Blue Cross Blue Shield and others, there was a plan that was designed specifically for Alabama called All Health to close our coverage gap. And it wasn't exactly Medicaid expansion as was envisioned. In other words, it did not take all of the uninsured individuals and put them on the Medicaid rolls. It was a public-private partnership, and that, along with the little bump that I mentioned earlier from the federal level in the match rate, would not have cost the state of Alabama any money. We would not have to had increased taxes. We would not have to found a revenue stream. According to Dr. Daravi, who is the state's top economist for at least 15 years, maybe more. I don't have an answer to why the state chose not to go ahead and move forward with that, other than we were hard at work trying to get everything aligned so that we could. Because you're right, the uninsured and the uncompensated care that hospitals provide is the reimbursement issue I mentioned a minute ago, probably one of the largest drains on hospital financial resources, particularly in the rural areas. An hospital is the only provider required to treat through the emergency department, regardless of an individual's ability to pay. So the number of uninsured individuals that come to hospital emergency rooms looking for primary care is higher than it ought to be when we have had opportunities in the past. And I'm not saying that the door is closed on closing the coverage gap now. We just have to go back to the drawing board to find a fiscally conservative way to do it in Alabama. So it will remain a priority goal. I just don't know what our options are going to be now, absent new revenue coming into the state.
It makes sense. Well, and people that are in Alabama listening to this, they understand the challenges of healthcare funding in Alabama. People outside the state don't necessarily appreciate that as much, but it's essentially a quadruple whammy in Alabama because on the Medicare side, you have the wage index that is lower than average, actually one of the lowest in the country, which is a problem because that affects, well, I didn't know if it was actually the lowest. That makes things worse.
It is.
So you have that. Then you have Medicaid funding, which is one of the lowest, if not the lowest in the entire country. Then you add on top of that, we don't have, I'm going to say this with kindness, our commercial insurance business is not a very competitive industry. We have one dominant player in the state of Alabama that controls most of the commercial. So the opportunity for negotiation can be limited. And then the fourth element of it is Alabama has a higher than average uninsured population. So when you add all four of those things together, I actually was talking to a Alabama CEO just a few months ago, and he literally threw his hands up. He said, I don't even know where to start with that because improvement in two of those areas would be a game changer for my organization. Improvement in all four is impossible. I'm a realist. That would never happen. But there's got to be some breaking point when you have all of those factors working against healthcare providers in the state of Alabama.
Yeah, no question about it. Well, we'll start with one. I'm not throwing my hands up with anything yet, but it does get quite frustrating. On the wage index, as you know, that's Medicare.
Yeah.
And actually, we've been working on that my entire career. That has been a part of our agenda. So that's how hard it is. And that's because at the federal level, that funds the Medicare program, in order to address Alabama's low reimbursement, which is the lowest in the nation. It's a finite bucket of money and can't go any higher. There's no new revenue coming in. So to change a formula so that states like Alabama do better, you have to take away from those who get sometimes 3 or 4 times the amount that Alabama gets. And as you might imagine, those are larger states that taking away from becomes more of a challenge. So we continue to work on that. But what the CEO you just referenced mentioned is exactly right. We've never claimed, and I never will be able to claim, that any one thing is going to fix all of our problems, but any one of those things you just mentioned could absolutely turn the boat around, could actually put us on some sounder footing to do other things. So yes, you're exactly right. And $650 million a year is about the average of unreimbursed care that hospitals provide. Just that alone could actually help us to rebuild and reopen and have more resources available in some of the services that have been cut heretofore. So I'm looking for that one thing, and we're continuing to advocate for those, and we'll not let up.
Yeah, makes total sense. It just makes your job harder, but it also creates a great job for you too, because the challenges just will never end in the state of Alabama. Not that I see.
Opportunities.
Yep,
Opportunities.
absolutely. All right, certificate of need. So,
Mhm.
certificate of need in the state of Alabama, I know some would argue that it has been reformed over the past decades, but compared to other states, that's not reform. You've seen almost, it's not technically, but you've almost seen an elimination of certificate of need in other states that are across the Southeast. But Alabama has held firm on their certificate of need laws, which are fairly daunting. So, talk to me about certificate of need in Alabama, how it impacts healthcare providers, particularly hospitals, and if you see any changes that may be coming down the pipe over the next decade or two.
Well, I'm going to come to maybe disagree with one thing. I don't think our CON law is daunting necessarily. And, a lot of the reforms, such as in North Carolina and a couple of other states who recently made some changes, some of the changes they make in their program or they're making now are things that we did in 2002. So we did have a very comprehensive reform, and it has been a long time ago. I don't know that I think that our program or that our members, what I think doesn't matter. I don't know that our association and our membership feels like it's a daunting process. Could there be some reforms to help the process along? I don't know. I'm certainly always willing to sit down and talk about it. But, a lot of the things that CON does and doesn't do. Again, this is another one of those, you understand CON, but a lot of other people do not. If CON, first of all, Medicaid could not have the budget without CON. But CON is not just about finances or turf, it's about the allocation of resources. No, we do not have staff enough to cover everything that we need to cover in hospitals now. If you start opening additional facilities, duplicating services that are available in a short amount of distance from each other, who's going to staff all of that? How much is that going to cost? And what does that do to quality? There's debate on both sides of the issue on the quality thing of it, but I speak for myself personally on this. If I've got something, a heart condition, and I need heart surgery, I think that the physician and the facility I'm going to look for is somebody who maybe does 500 a year instead of 50. So the appropriate allocation of resources and staffing, I think, matters for quality and for the availability. So it's not as much protecting turf as maybe it once was, as much as protecting the resources and making sure that we don't have 10 or let's just say 5 different providers doing the exact same thing in a community when maybe just 1 or 2 is all that's really needed to cover the volume.
Yeah. Well, and people who criticize CON will say, well, it's not a free market economy. It's not a free market economy principle. But I think what they miss is that healthcare is not a free market. It's just not.
Bingo.
Yeah.
It's not.
And so when you start using that argument to argue in favor or against certificate of need, there's a fallacy in your assumption. And the power of
there are more. Sorry.
Continue. No, continue.
No, I was going to say, there are more states with CON or with some form of regulatory process like CON than there are those that don't have anything. So some states that said, okay, we abolish CON, but what they put in place is very similar. They just don't call it that. So there are more states who have those type of regulatory process to look at the allocation of resources and where they're going to be than there are states that have nothing.
Excellent point. Well, Dane, this has been fantastic. I really appreciate you investing time coming on the podcast. Very interesting times in healthcare, but I think they're all interesting times. We've gone through decades of interesting times, and I think that will continue. So congratulations on your promotion. Thank you for your leadership. Thank you for everything the Alabama Hospital Association does, not only for the citizens of Alabama, but the impact you have nationally.
Right back at you, and check back as things progress. Who knows what else, new things we can talk about more.
Excellent. Definitely will. Thanks so much, Dane.
Thank you for the invitation.
Thank you for listening to the Healthcare Badlands podcast. As always, please like and subscribe so you don't miss future episodes. If you have suggestions for topics or guests, please email those to podcast@badlands.pro. This podcast is for informational and entertainment purposes only and should not be considered legal advice. Some information shared may include fictitious names. The opinions expressed are solely those of the host and/or guests and are their own and not reflective of the opinions of others or our sponsors. Thanks again for listening, and we hope you'll join us on the next episode of the Healthcare Badlands podcast. Until then,